Okay, so we're going to talk about joints, which is chapter 9, which is the last chapter of our exam 2 material. So a fancy word for joint is an articulation. A joint and articulation is anywhere where two or more bones come together. And typically, bone on bone does not touch. You're going to have a type of cartilage there. We do also consider where teeth and bones come together as a joint, even though technically a tooth is not a bone. So arthrology is the study of joints, how they move, what are the different disorders, etc. And basically every joint of the body we can classify two different ways. We classify it based on the material that makes it up, which is the structural classification, and how it moves, which is a functional classification. So structurally, we have actually both. We have three different types. So it can be fibrous if it's usually collagen fibers that are connecting the two bones together. If there is a type of cartilage between the two bone ends, then we call it cartilaginous. And then lastly, synovial if it actually has a joint cavity or space between the two bones. Functional classifications. Synarthrosis means it does not move at all. Amphiarthrosis, slightly movable. Diarthrosis, freely movable. So again, this just gives a little bit more details of what I was talking about earlier. What you'll notice is, again, only synovial joints will have the fluid-filled cavity, basically with the lubricating fluid to help the bones move very easily. The other two will not have a joint cavity. So again, if it's dense connective tissue, again, I mentioned typically that's collagen fibers. It would be a fibrous joint. And if there's cartilage between the two, it's going to be cartilaginous. So syn without, so that joint does not move at all. There are obviously times where you would not want that. You don't want your teeth moving within your jaw. You wouldn't want your cranial bones, okay, moving. Amphiarthrosis, slight movement, and then diarthrosis are freely movable. And what's important to note here is all synovial joints will be freely movable. That's why they're going to have the joint cavity there. So synarthrotic and amphiarthrotic joints, both of these will either be fibrous or cartilaginous. So we look at, of course, the synarthrosis, amphiarthrosis. Synarthrosis is how we describe, in general, how the joint moves. And basically what we see is the more mobile a joint is, which means the more it moves, the less stability factors that it has. That's why it moves that much. The more stable a joint is, the less mobile it's going to be, but the more secure. Okay, so first we're going to talk about fibrous joints. So we already kind of talked about the characteristics. So on the exam, I'm going to give you a specific type of joint. These three are all specific types of joints. And I would expect you to tell me if it's fibrous, cartilaginous, synovial, and then what type of movement. Is it synarthrosis, amphiarthrosis, or synovial? Okay, so we're going to talk about the three most common types. I'm not going to make you know every joint in the body. You only need to know the ones that we specifically talk about in this presentation. So gomphosis is what we call when a tooth is fitting into a socket within the jaw, which is what we call an alveolus. So there is a periodontal membrane, which is a fibrous type of connective tissue which holds the tooth into the jaw. These are both fibrous, of course. Both gomphosis and sutures are immovable. Okay, so they're both going to be classified as synarthrosis. So a suture, y'all have named this as bone markings. It's where cranial bones come together. Again, you would not want movement here. It helps, instead of having a solid bone, of course, it allows for growth of the brain, and it does give more strength and decrease the chances of fracturing, breaking cranial bones. So basically, in the child, okay, if these are my two, let's say this is parietal bones. you're going to have a decent amount of space, especially a newborn baby. That's what we call fontanelles. So as we get older, the amount of connective tissue between the two bones decreases. So the bones slowly grow towards one another. And by the time it's an adult, they perfectly lock together. And I say adult, really here you're probably talking about around 40. Completely locked together, they no longer need the fibrous connective tissues that are connecting those bones. So that's when we change the name of it to a synostosis. Remember, osteo is bone, so it's completely bone. No soft tissue there anymore. And the last type of fibrous joint is what we call a syndesmosis. This is the only type of fibrous joint we're going to talk about that does allow for very small amounts of movement. So we have it between the radius and the ulna. It's this little fibrous membrane, basically between these portions, as well as on the distal portion of the tibia and the fibula. Technically, in that example, it doesn't allow for any movement, but I wouldn't really ask y'all that. So this is our interosseous membrane, okay, that's connecting slowly. And basically, with the radius and ulna, which is the one that we have depicted here, it does allow for a little movement. So when you want to supinate or pronate, the head of the radius will basically turn towards the ulna or away. So it allows for a pivoting movement. This specifically, though, is a type of synovial joint. So within bones, you can have two different joints here. So right now, we're just talking about this portion, the interosseous membrane. Okay, now we're going to talk about just two types of cartilaginous joints. Again, they're going to have cartilage. Because of the locations where elastic cartilage is in the ear and epiglottis, it's the only type that's not involved here. So it's either going to be hyaline cartilage or fibrocartilage. Basically, if it's synchondroses, it's hyaline. If it's symphysis type, then it's going to be fibro. Again, it's not a type of synovial joint, so it's not going to have a joint cavity. And these are going to be like the fibrous, either immovable, synarthrotic, or slightly movable, amphiarthrotic. So again, synchondrosis is going to be hyaline cartilage, and these do not allow for any movement at all. Okay, so they are synarthrotic. The examples would be hyaline cartilage within the epiphyseal plates of a long bone, which of course this joint does not last forever. Okay, as soon as the epiphyseal plates stop and you have a line, that would no longer be a joint. And then we call the costal cartilage, the hyaline cartilage that connects ribs to the sternum. And then symphysis, again, is going to be fibrocartilage. So fibrocartilage absorbs shock better and compression more so than hyaline cartilage does. So these do allow for a little bit of movement, okay, that we call an amphiarthrosis joint. So just think about the areas where we have fibrocartilage between bones. There's three locations. One of those is the knee, which is a synovial joint, so that's the only one not included here. So the pubic symphysis, which is between the two coxal bones, specifically the pubis bones of that portion. In pregnancy, hormones make this relax a little bit, so it allows the female's hips to widen slightly, which of course makes the birth canal slightly larger. And then the intervertebral joints, the areas between our vertebrae and what we call the intervertebral discs. Okay, so just an example, we have the costal cartilage and the epiphyseal plates. Those are hyaline. That's a type of synchondrosis that does not allow movement. And then we have symphysis, fibrocartilage, and the pubic symphysis in between vertebrae. Both of those do allow for a little bit of movement. Okay, synovial joints, most of you, when you think about a joint, you are picturing in your head or thinking about a synovial joint. These are freely movable. They're the most common. Because they allow for movement, though, they're the most complex, and sometimes the type of movement that we have there is not a movement that we really want in that joint. And when that happens, you can have problems, you can have injury. So again, all synovial joints are going to be diarthrotic, which means they are freely movable. And all synovial joints of the body will have, at minimum, these basic characteristics or features that we're going to talk about in more detail. And just a small note here, most synovial joints are within your appendicular skeleton. So the characteristics that all will have, they're going to have an articular or joint capsule, which has two layers. The outer layer is fibrous, so that's going to be dense connective tissue. Technically, it's dense irregular connective tissue, so it allows for pull in several different directions. Where dense irregular is also what we find within the reticular layer of our dermis and our skin. And the inner layer, we talked about this with membranes, is the synovial membrane, which is the only type of membrane that's not comprised of epithelial tissue. It's going to be made of loose areolar connective tissue. The synovial membrane is on more the internal portion, and it's the capillary beds within the areolar that actually help make the synovial fluid that helps lubricate and is found within that joint cavity. Articular cartilage we've discussed before with the long bone. Remember, it covers the epiphysis of the long bone. So it's going to reduce friction when those two bones move. And again, it does allow for a little bit of shock absorption and compression, although not as much as fibrocartilage. Where articular cartilage is the only type that does not have a perichondrium, that membrane that surrounds it. And like all other cartilage, it is avascular. So it's actually the synovial fluid, which will have some nutrients, oxygen, that's going to help give this articular cartilage and try to help keep it healthy. So synovial fluid is, of course, it's viscous, it's fluid-like. It has hyaluronic acid and other enzymes that really help to lubricate and keep the health of the joint. So it's going to make it easier for movement, kind of like WD-40. As I said, it nourishes and removes waste from the cells, the chondrocytes in the articular cartilage, because it's avascular. And having fluid there also does help absorb some shock and some pressure in that area. So all synovial joints will also have some ligaments and tendons that will help provide stability. Typically, the more ligaments and tendons that surround a joint, the more stable and less mobile that joint's going to be. Both ligaments and tendons are made of dense regular connective tissue. The difference is, what do they attach? So ligaments attach bone to bone. Tendons attach muscle to bone. So basically, ligaments, joints can have several different types. They can have what we call extrinsic ligaments. Extrinsic are found exterior to the joint capsule. They can be inside the joint capsule, what we call intrinsic, or they can actually be part of the capsule. We call those capsular ligaments. That's not up here. Tendons, because they attach muscle to bone, technically they're not part of the joint. However, when the muscles are slightly tight, the tendon's going to be tight, and it does help provide stability for that joint. Again, the more tendons that you have, it can limit the range of motion of that joint. So this is just a very general picture with the basic characteristics of any synovial joint. So again, you're going to have the articular cartilage. It's going to be on the ends, the epiphyses of the bone. We are going to have the purple here. That's representing the synovial membrane. Okay, so it's going to make the fluid. That's what you see purple here, the fluid that's going to help lubricate those two joint areas. And then just external to that, still kind of a little bit of this bluish. That's going to be your joint capsule, which is the dense, irregular connective tissue. And then the white here could just represent any extrinsic ligament that you might have. So all synovial joints have the characteristics that we talked about earlier. Most synovial joints will have accessory or additional structures, and the purpose for all of these is going to be to reduce friction between the two bones or 3 or 4 bones that are articulating there. So one of the first ones is bursae, AE against plural. So these are fibrous sac-like structures that contain synovial fluid. So it's basically like you have this little ball, the red line would represent the synovial membrane, and that makes a small amount of fluid that basically fills that area. I kind of say they act like ball bearings. So wherever you could possibly have friction, wherever bones could be rubbing against ligaments or muscle or skin, you're going to have these structures. Then what's very similar to the bursae is what we call a tendon sheath. So it's an elongated bursa that wraps itself around a tendon. Again, tendons where they attach to bone, you're going to have friction there. So these are especially really common and important in the wrist and in the ankle. And then you can also have fat pads. So we talked about adipose or fat before. It is a nice packing material that can cushion. So it helps cushion, again, provide a softer tissue between maybe bones or bone and ligament. It's usually on the outside of a joint, again, protecting the more internal spaces. And in the body, we never just have open spaces, so it would fill any areas for when maybe your knee is completely straight or when it's bent. You're going to have fat that's going to fill in the spaces as you move that knee. So this is actually a picture of the knee joint, and it's showing all of these structures. Actually, I say that, sorry. It does not have the elongated bursa sheaths, but it does have the little bursae. Okay, so these little, basically ball-bearing-like structures that have a little bit of fluid, so whenever you move, they're going to reduce friction there. And then, of course, you see all the different fat pads. We have several different fat pads of the knee that are going to help cushion as well. This is an example, and the foot looks very similar. These blue areas here that are extending, again, where the tendons and muscle and bones could rub, that would be where you would have the tendon sheaths that are reducing friction. Okay, so we talked about 3 different types of synovial joints that were fibrous. We talked about 2 different that were cartilaginous. And now we're going to talk about 6 different ones that are synovial. And remember, all synovial are diarthrotics. They're all freely movable. However, not all synovial joints move to the same degree. So here, plane, these would be the least movable. And as we make our way down the list, ball and sockets would be the most movable. So for any of these, I expect you to know this would be the specific name of the joint. So if I gave you a plane joint, I would expect you to know. I usually don't have the description. This is just more for y'all. So it's uniaxial, only moves along one plane. The surfaces are flat. Typically what I ask, I would expect you to know between the carpals or between the tarsals that is a plane joint. And that a plane joint is diarthrotic, and of course it's also synovial. So for hinge is going to also be synovial, diarthrotic, and examples of the body and the elbow, the knee, between the phalanges, also your jaw. Pivot is also synovial and diarthrotic. So one surface of the bone is going to be perfectly round, the other is going to rotate around it. 2 examples between the radius and the ulna, and then also your atlas and axis, or C1 and C2. So if you remember, C1 was almost just like this little ring, and then you had the little transverse ramen. You did have little masses here, but it's this open ring. And then C2 fit in that. So C2 had that little process. And so basically, your C1 and C2, you can rotate around that dens, and that's how we shake our head no. Okay, so that would be a pivot joint as well. Condylar, also sometimes called ellipsoidal. All the previous ones have only moved along one plane. Condylar and the next type move along two planes. So the surfaces here are going to be rounded towards one another. So it allows a little bit more movement. You have this between where your hand joins the phalanges, what we call digits 2 through 5. So everything except the thumb and your big toe. So the thumb and the big toe have a little bit more curvature, which allows for slightly more movement. They're what we call a saddle joint. And then the most freely movable synovial and diarthrotic joints, of course, are the ball and socket. Two examples, the shoulder and the hip. Out of the two, the shoulder has the most movement. So again, it's going to be the less stable, which is why the shoulder does get injured a lot. So movements of the joints are somewhat difficult to demonstrate here, so I'm going to talk about those with y'all on Tuesday. We're actually going to all do those together and demonstrate. Okay, so I'm going to be doing movements in class then. These are some specific joints that we talk about. Most of this is kind of just interesting. What I really would expect you to know from the, call it TMJ for short, temporomandibular joint, that's your jaw. Okay, so that's a type of hinge, which of course also means that it is diarthrotic and synovial. So this is just showing, it's a very shallow joint, it's easily dislocated. You have the joint between the clavicle and the acromion process. That's a planes that allows for very little movement. Of course, the more movement is between the actual head of the humerus and the glenoid cavity or fossa, which is your ball and socket joint. Again, it's not very stable because it allows for a lot of movement, so it's easily dislocated. And it's really uncommon when you dislocate this joint that you're going to injure the muscles that surround and help hold the humerus into its socket. And those are what we call rotator cuff muscles. This is the really general kind of name for the group of those muscles. Y'all probably heard of those before. So again, those can get easily torn when you injure your shoulder. Okay, so if you look at the shoulder compared to the hip, the shoulder, the ball and socket is much more shallow. Okay, it's deeper in the hip. So the hip does not allow for quite as much movement, but it is more stable and less because of that. Okay, so the hip joint, gets more stable but less mobile than our other ball and socket. It needs to be more stable because, of course, all the weight from the upper body is on the legs, on the hip joint as well. Again, all really these really specific parts I'm not going to ask you about. So what we see, though, this is just kind of interesting. Stability from the hip can be several different areas. So again, I mentioned it has a deeper socket. The articular capsule is stronger. It has more ligaments and more muscles, which help to pad and surround that joint. Again, we will focus on movements on Tuesday in class. Those of you that only have class on Thursdays, of course, I will discuss this with y'all on Thursday. Okay, so again with the hip, notice how much deeper the socket is. There is an additional ligament here as well. If y'all remember the fovea capitis, it was the small little like notch on the head of the femur. That's because this little ligament attaches here. So there's a small ligament. It's called the labrum. It basically attaches from the head into there, so it allows for additional support. The knee joint is the largest and it's the most complex diarthrotic joint. technically, there are three different areas here. I only focused on the two main. So primarily it's a hinge joint. So between the lateral and medial condyle of the femur, the lateral medial condyle of the tibia, that's hinge. Okay, we call that technically the tibiofemoral joint. Most of the time when people are talking about the knee, this is really what they're thinking in their head. This is what they're referring to. But technically, you also have the patella and how that slides past the femur as well as on the tibia as well. Again, though, we really focus on the tibiofemoral joint, which is our hinge. So you have several different structures in the knee. Like all other synovial joints, of course, it has an articular capsule. We have our quadriceps femoris muscle group, which is in the anterior thigh. The tendon's going to attach there, so it helps hold the patella in place. You have a patellar ligament, which attaches from the patella to the tibial tuberosity, that little bump on your tibia bone. And then because this joint has so much weight that bears on it, we have additional structures, fibrocartilage pads, called the medial and lateral meniscus. So 2 fibrocartilage pads for each knee. So these help cushion and stabilize the joint as well. Usually I don't specifically ask about these. Y'all just hear about these all the time. ACL, PCL. So cruciate ligament. Cruciate means it crosses. Anterior, of course, it's on the anterior surface. So anytime you try to hyperextend the knee, it's very common to injure the ACL. Other times you can also injure the ligament which crosses more on the posterior portion, the PCL. You do also ligaments on either side as well. So of course this is the ACL, this would be the PCL. This is the PCL, notice the crossing. And then you also have the ligaments that are going to attach from the lateral and the medial portions, trying to stabilize the knee joint. And then as we mentioned earlier, these would be the medial meniscus and the lateral meniscus. Medial meniscus, lateral meniscus. Okay, so issues, homeostatic imbalances of the joint. We mentioned the epiphyseal plate. If you happen to fracture, break a bone in this areas, then you basically can create an issue where the epiphyseal plate does not divide as much as it would be, and so the bone might be possibly shorter. And any time that you injure parts of the body as well, you have a much greater chance of developing arthritis in that joint later. So there's several different types of arthritis. We're going to talk about the 3 most common types. Rheumatic or rheumatoid arthritis specifically has a lot of inflammation, swelling within joints. It's within the articular cartilage and synovial membranes themselves. And with this one particularly, it's what we call an autoimmune disorder. So that means it's your own body cells that are supposed to be protecting you, types of white blood cells, and they're attacking the synovial membrane, which affects, if that's not producing enough fluid, that's going to have extensive damage to the articular cartilage. So you have a lot more friction, therefore that creates a lot of inflammation. If that doesn't get fixed, you can have degeneration of the bone, and the bone ends can start to fuse together. Osteoarthritis is more what we call natural wear and tear on the joint surfaces. Most Americans will develop at least some form of osteoarthritis in joints. Again, if you've injured a joint or area, bone, definitely probably going to get osteoarthritis there. Can be autoimmune areas linked to this as well, although you definitely see that with rheumatoid arthritis. The other type that's very different, this is actually the only type that's more common in men than women, is gout or gouty arthritis. This is when you have an increased amount of uric acid crystals that sit within the synovial fluid. And basically, they can kind of protrude into the synovial membrane and articular cartilage, causing a lot of pain. Most commonly, you see this at the base of the big toe. And one reason why we see it more commonly in men and women, it's not uncommon for people that consume larger amounts of red meat or alcohol. They typically have more uric acid crystals. And so, what can you do to basically try to help keep your joints in as good a shape as possible? You want to increase the synovial fluid to the chondrocytes and your articular cartilage. So basically, that means you want activity. Activity in the body's good. You want to make sure that you stay hydrated. When you get super dehydrated, like in the flu, you might notice that your joints are kind of achy. And that's because you don't have enough synovial fluid. And so you have more inflammation in those joint areas. Making sure the muscles that surround that joint are strong. That's going to help to stabilize the joint. And then you also need to listen to your body. So when things are hurting too much sore, it's good to take a break and not to overwork the joint. You don't want to aggravate problems.